Well, we're rounding out the trauma section. Remember your head to toe assessment. It's very important to find those injuries and treat those life threats. So in the primary assessment is part of also your head to toe. As you go down the body as a reference map for finding these injuries, you need to treat those life threats. So as you take, you start off with the head and you're looking at their airway. And if they're gurgling and there's secretions in there, no suction, you'd have to do something. What would you do? Now, if the airway is clear, but there is an obstruction because of the anatomical obstruction, which is then you would put in an oropharyngeal airway. But the oropharyngeal airway can only be used if the patient does not have now if you use the NPA because they have a gag reflex, then what can happen if you force that NPA into the nostril? That will make it more problematic. When you have all of this bleeding and epistaxis everywhere, it's going to make the airway more problematic, and you got to move to the next step, which is reestablish breathing. So now, what is the normal breathing rate for your patient? 12 to 20 for an adult. 10 to 12 for an adult, 12 to 20 for your adolescents and pediatrics. You want to maintain that breathing pattern. Remember now, your head injury patients can breathe very slow, bradypnea and hypoventilate. They can also have irregular breathing patterns called chain-stop, Biot's breathing, and apnea, agonal. So look up these terms. If you didn't go over them and you're a little confused, you can use multiple media sources to find out these breathing patterns. Again, there's chain-stops, there's Briot's, there's neurogenic hyperventilation, there's agonal, and there's apnea. So look those up as far as airway things, and that's where we're going to reestablish breathing. If they are breathing, then we need to provide supplemental oxygenation. That means requiring the pulse oximeter to be on. We don't necessarily put the pulse ox on immediately. We'll go ahead and treat the patient, and then when we can, we put those additional diagnostics on. And remember that a pulse oximeter may not work or function very well either because of nail polish, either because of lack of blood flow there when they're in shock, either because of the environment is too cold, or maybe they have been overwhelmed by carbon monoxide. So it's just a diagnostic tool, but we can see that if our patient is cyanotic on the lips and the nail beds look cyanotic, then we assume that their pulse oximeter is going to be that good, right? Okay, DCAP BTLS and your head to toe assessment go together. As you continue to finish out your head to toe exam, finding your injuries, you can come back and be more specific. Don't forget to deploy the neurological exam, specifically if they're a head injury, if there's a spinal cord injury, if they're disoriented or altered. Remember what acronym for altered mental status. All right, so our multi-systems trauma patient will require us to be very keen on understanding the mechanism of injury and putting together what type of assessments we're doing, and when we do our head-to-toe exam, what we are finding. Again, a multi-systems trauma patient is one that is affected by more than one system of injury. For example, if they have a head injury where the brain has caused a lot of swelling, and the lining that lines, the dural lining that lines the skull cap is being torn away because of a high arterial bleed, and they have a sucking chest wound, and they have an open tib-fib fracture to the leg, this person has three systems going on, or three organ systems. This is a multi-systems trauma. It's going to take a lot more assessments, a lot more treatment, and the person is going to require a lot more at the hospital. So multi-system trauma patients are significantly much tougher to deal with in the pre-hospital setting than a single isolated closed mid-shaft femur fracture, for example. Here we have a slide where our providers are evaluating a patient. Somebody is doing a immobilization of the head. They've obviously done the primary assessment, which is airway, breathing, circulation, the general impression, orientation, and the chief complaint. And this person is supine. I would assume, based on this picture, the person either tripped and fell down the staircase, but they could have slipped and fallen in that living area. Looks like they have an injury to the right lower extremity. We know that those bones down there are the... So as they're measuring and evaluating the distal tib fib, he should be checking the CMS, or circulation, motor, and sensory. He wants to also try to bring that other leg out so that we can evaluate both sides. We want to make sure that there's no deficit bilaterally when we're evaluating this. You should bring out a trauma shears and try to cut and expose. Remember that there may be an injury there, but there may be other injuries further up on that leg or somewhere else on your patient's body. Pediatrics are another special case, and remember when we talked about spinal immobilization and spinal precautions, spinal motion restriction, this spectrum of how we evaluate and then immobilize the patients if we suspect some type of neurological or spinal cord injury. These patients may not understand the words or the questions when we ask them. They may require us to have a go-between, such as a parent, or we may not be able to believe their statements when we ask them these questions, and so we end up placing them inside a spinal immobilization device. Now, the backboards seem to be much larger than the size of a pediatric or a child patient. And so yes, it does look like in this case they might be using what looks like to be the kid. You know, and they're just securing the body. Now we can use a large leg splint, and there's also a pediatric spine board which is much smaller and much slender, but it requires a different strapping sequence, and it's usually velcroed together. So as you get out there and you're working in the field for pediatric patients, look at their equipment. It takes a little more than just a few more practices, but the idea and concept's the same. We are strapping down the torso, the pelvic area, and above the knee. We are securing the head last. It still requires you to use the neurological exam, which consists of pupils, motor, sensory, and pulse functions of the upper extremities and the lower extremities. Don't forget, geriatric patients fall in that same condition, that they may not understand what you're saying, either because of their cognitive decline or maybe they're unable to hear. And in this slide, we're looking at somebody that may have the mental capacity or incapacitation to understand the questions that we're asking them. You may need to use the provider that well recognizes, knows their types of body language, and can understand what the patient is trying to tell you. Here, our provider is getting towards an eye-to-eye level, bringing their silhouette down, and I imagine that the person is using a softer voice and deliberately explaining things as she does her exam to this patient. Keep in mind that when we have a multi-systems trauma patient, we are communicating early to the hospital to let them know what type of patient that we have, and that they will have to prepare to receive the patient that we are bringing in. This may require them to bring down more than just the emergency room doctor and personnel. We ask for blood to be tubed up or brought up to the emergency room, specialty devices such as a portable x-ray or a ventilator machine, additional personnel such as an anesthesiologist, a respiratory tech, ultrasonographer, to have the CAT scan and all other medical equipment ready to go when we start to announce what type of patients we are bringing in. Being here on an isolated island where our trauma center is at level 3, we need to understand that when we take our 10 minutes at the field and we delay transports, we're delaying that golden hour for that patient to get into surgery. And knowing that we are far away from our trauma center that resides on Oahu, we still need to activate aircraft and air medical personnel to ship our seriously injured multi-systems trauma patients to those facilities to get that specialized care. Please study your textbook, lecture notes, PowerPoints, and National Registry skill sheets. This concludes our trauma session, and I hope to use the PHTLS to increase our knowledge base.